Okay, great. So this uh, conversation between the logic liaisons and social determinants of health group started about 6 months ago or longer ago, and our goal was to establish kind of a core set of SDOH variables that were available now that we would join into our fact tables. And so we landed on these, the Boston Share Care variables that they're going to talk about today. And SDOH recommended a group of those for inclusion. And to get to the fact tables that use those, I'll just share my screen. You seeing the enclave here? So you come to the knowledge store. Excuse me. The fastest way to find us is to type logic, and if you can spell liaison, liaison. But you can just search on logic and you'll find our templates usually. And so the main fact tables are here. These are for level 2 and level 3 DURs. So if you open this, I'm going to just show you, I'm not showing you everything about this template again, but just the README here does have a data dictionary in it, and we'll take a look at that in a second. But we also have then the template workbook is here, or you can import the template into your workbook. You can also import the data sets into your workbook, and so the data sets are available by browsing into the right folder for your DUR access, and then you can see them here. I'm not going to open them up since we're on the real data there. But the README does describe what we have in those fact tables, and just the level 3 one is joining in the social determinants of health data because we're using zip code and a crosswalk that Jimmy can speak to that he created for the county to zip code. And it has the link to the data set that we're using here, the Boston Share Care data set, and then you can see the variables that this team, Charisse and Jimmy and all, have recommended as the best, most kind of usable ones for us to join in. And so those are here, all with the asterisks, because they only apply to level 3 data. So you have these in our fact tables at a patient by patient level based on their reported zip code. If the patients don't have a zip code, or their zip code is maybe international, is not in the crosswalk table that we have, then they will not have values for these. So remember, these are geographic. These are not on an individual basis, but might speak to the region where the patient lives and kind of the social determinants of health in that region. I think that's all I wanted to say.
Okay. Well, Jimmy, you're in the hot seat.
For whatever reason, I couldn't figure out where to unmute. Okay, so I'm going to give the talks that we had previously given last week at the AMIA Informatics Summit, and talk about this in the context of what data is used in the DUR in the Enclave. So we had been looking at different types of data sets in order to characterize what is census or even individual level information on patient social determinants of health, and then separately community level social determinants of health. Some of these things are very much structural information that we can get from census. This was from a paper that we had published about 2-3 weeks ago, and there's a long list of actual the variables names, but for simplicity we just kept it up to like what kind of category or factor those things are. In the Enclave, as well as in the analysis that we recently published, separate paper, but this is the one that uses the social determinants of health information in the Enclave. we broke it out into like variables from the social deprivation index on, percent Black or percent over 65, percent foreign born in a county level census community level information. And some of these this is basically Juan Espinoza's representation of what each of those variables mean, and framed into the context of, is this meant to indicate vulnerable populations or resource deprivation or access to care issues. This is a lot of variables because we're using not one external data set, but I think maybe 7 or 8. And then there's even more that we had requested to be ingested into the N3C Enclave. But it was like a long queue to get a lot of these data sets in, and we sort of wanted to make use and show value of the data sets that have been ingested. What we did was, this was part of a study that was looking at county level social determinants of health, looking at the time windows from when the county had their first declared cases of COVID, and is it 30 days and 60 days or 90 days or 120 days, 180 days? How far out do you want to go, and what kind of features are showing up about important social determinants with regards to the counties at that time? I was hoping like Charisse would be on here because she would be able to speak to like the final figures in that paper a lot better. But what was ingested into this at the time was basically we had the N3C data, but I think for the study that was recently published, we didn't actually put these with regards to just the social determinants information. We were using the county level COVID-19 county daily status. It's one of the data sets that N3C put together. And this provides for every day for each county and for the adjusted rate based on the county's expected population at the start of the pandemic. So all those features are actually available in that data set. And we sort of supplemented that using the social deprivation index for a lot of those resource and social deprivation features. There was the food access research atlas. I think this gave information on like how far, well, I'm sorry, what's the percent demography in each county. It actually goes down to census tracts, but we just need a county. And then how far is the distance to the closest hospital? So there's actually some information in there for access to care, but we didn't use that in here because there's just better resources for it. The US Census American Community Surveys is a good fresh resource for that, for a lot of the percent demography, population estimates, and we also used the BU Share Care dataset, which also leverages the Census American Community Surveys. I think that sort of wraps it up in a nutshell. These are the data sets that we originally had intended for this kind of research. And then we had placed it in the frame of like, these are what each of those variables might mean. And we were looking at each individual variable for their importance towards likelihood to be catching COVID. Okay. Now, in our DUR, this is something that we frequently get asked, like, why did we include so-and-so data set? We originally scripted this out to talk through, like, what's the frame of this project? What's the rationale? What are we intending to look at in the general sense? And then we can ask more micro questions as needed. But for each of the data sets, we actually did explain, like, we wanted to use this data set and exactly like it provides county level daily measures and case incidences. And a lot of this can be providing global measures relative to the N3C's data set, or the social deprivation index, which actually is a derivative of the Census American Community Surveys 2015 version. And in relation to other census-based data sets, they're all sort of like different representations of time. And we felt like this one was actually talked about the most and useful at both the census zip code and census county level. So this was one of the ones that were asked for ingestion. But yeah, for basically each of those data sets in that table, we had a small blurb to just kind of put it in context. And I think each of those data sets have been ingested into the Enclave, having the original provenance of like, what is this data set from the source. So that's what Palantir had done. But this is our short blurb. And if you're interested in any of these rationale, just reach out to us. This is in our social determinants of health Google Drive folder and totally intended for like any collaboration use.
Do you have the BU data set on there?
EU.
The share care one?
No. I think that's one of the ones that came afterwards. Once Bill Adams had introduced us to Nina Cesar and James Boyd. I forget his last name, but no, the rationale for BU is not on here. Sorry. But that's something that I should probably track down.
Jimmy,
yeah.
is this information available? It's just in this Google Doc?
I'm sorry?
Is this information available in the Enclave next to the data sets as well, or this is your own summary?
So with each, if you go to the knowledge store and you look up each of those data sets, the metadata for each of these data sets will refer to what was on the source website. So it's not this. This is what we had written as like a simplified way to explain why are we going to use this and where would you go to get that information. But yeah, so this is actually in our Google Drive for the, as part of our DUR. But it's not in the Enclave. You just reach out to us and we'd be happy to share this. So that's what I mean. But if it needs to be in the Enclave, I don't know how to append that because these are our shorthand, like for explaining what's the utility of it.
Maybe I can work with you and we can, because we usually put together notes and materials for each of these things, including the recording. So maybe we could grab relevant sections and link to it from those notes for this. You just
okay. Cool. All right. So, are there any questions so far?
I think I just want to mention that the data sets, the public data sets, do have documentation in the Enclave that's existing, and so that's what we've used so far for the BU one, and that's I could share my screen real quick just to show how people get to that from our README while we're on the topic.
I think the documentation didn't come from me. That one actually came from Nina Cesar. Because she was also the one that helped ingest the data set too.
Okay.
Yeah.
So we have links up here in our README, in our Logic Liaison README, and then we also have links inside of the definitions. When you open the data set, Andrea's put these definitions directly into the descriptions column as well for every column. So
okay.
So unfortunately in the descriptions, the link, like the embedded link doesn't work. I could put in the path in that definition as well.
What do you mean the embedded link doesn't work? Is
So
that
when
not a
it's,
hyperlink?
no, it won't hyperlink it. I would have to paste in the actual link itself, and then you'd have to like copy paste it.
Joanna, is your audio cutting out?
And losing her a little bit too.
Okay.
It occurs to me that maybe not everyone here actually knows where to find these data sets in the knowledge store.
Well, I've watched it evolve, and it used to be in a different place, and then it moved several times. So it should be available in the knowledge store. So in it, what was it? So basically go to home, go to knowledge store, and then
I'll open a window and share.
yeah, a lot of the keywords for like SDOH or social determinants will lead you to those resources. You can, I'm not actually sure if this is still a capability people outside of a DUR can do, but if you looked up the social determinants of health domain teams DUR, and you could see all the resources that were mapped to it. Sean, is that actually something we can do?
In the, I think so. I can try it. Let me first just show where the external. So these are the external data sets are the ones that are sort of brought in from outside of the enclave, like publicly available things. So COVID-19 vaccine hesitancy. And then is there a search SDOH or something that I can put? Here's their share care.
Okay, so that's share care, but I guess you can't find our DUR.
I might be able to if I go and start browsing around the
oh, Charisse thought it was 1 p.m. Central time.
Uh-oh.
Oh, time snafu. Okay.
What's your DUR name?
I'm trying to figure that out. Let's see, it's like RP. Shoot.
Is it one of these?
I can't get in right now. C 1C1, 1C11A5. Yeah, that one.
So if y'all haven't seen this before, wait, no, I can't find that.
Well, yeah, I mean, if this is a good way to map it, that would be great, because a lot of those data sets we identified them, I don't know, the end of 2020, mid 2020, and it was a arduous effort to get a lot of these data sets in here into the enclave. But I think they should be mapped, and we are still exploring research questions with them. So if you need anybody to talk to about those, then that would be like Charisse, me, and a lot of the other subject matter experts. But in the documentation that we put in the enclave, we tend to put in what was from the data set source. So, not our own language about it, but what did they mean to represent for it. Yeah, but a lot of these data sets actually were generated before the pandemic. So they're general population social determinants of health measures, and might be a little dated. So it might be like from 2015. I think the oldest one was actually from social deprivation index. So from 2015. But since then, everything else is from 2017, 2019. Yeah.
Here's the share care.
Share care. Okay, so I guess if nobody else is here to like talk about what share care is, so this is a data set generated by Boston University, and it pulls data from American community surveys as well as a few other econometric data sets, I think from like AHRQ, and they will what is it called? They essentially will take into account a lot of these different demography measures in order to consider what's the wellness index in an area. What's the I wonder where's a variable for it. There's a composite measure that they have in here, and I think it goes from like 1 to 100.
Yeah, it's the, I'm sorry to be late. I'm so sorry. I had the I had the time zone written wrong. So I'm sorry to be late, but it's the SDOH1 and the SDOH2. So you just passed those. Okay. So these are their composite measures. So that those are the measures that for right now I would actually hold off on using, because they have the BU Share Care, the publication on that is not yet out, and they would like to, as part of the agreement, it says something like you will have to do allow BU Share Care to review the publication before you would use the measures they have generated. But part of the reason we wanted to upload this data set in is because it has a lot of county level census and then also HRSA measures. So a lot of the stuff like the healthcare access variables are in here. So it just has a broad range of variables from other data sources. And then we're hoping that we can get a little more clarity around using the SDOH indices. But for and it may be fine to use those. We can contact BU Share Care and just, they would just want to review anything that is using the variables they are creating. But we do have the contacts for that group.
Do we need to provide instructions for that? I think we have one of those that you had us include in the template. Do we need to provide some instructions in the README?
I think we probably should. We probably do need to get instructions, but I think that Nina was trying to get in contact with the group to provide. So they have this requirement that they want there to be some sort of review, but there aren't clear instructions on what that will look like, other than we will just need to contact the group that is has developed these scores.
Parliamentary procedure? Yeah. Is that what we need here?
Yeah, we may need. So for now, I think we can just say, and we can maybe add that to the README. We can talk to Nina again to see if there's we can give like a specific email at least of contact this person about using these. So I think that's something we could add.
Sounds good.
So let's say I'm working on a project and I'm using level 3 data. So I do have the full 5-digit zips. How can I make use of this SDOH information?
You mean at the zip code level as opposed to county level?
Well, I have whatever is in the default LDS.
Okay. So Jimmy, so if we want to use county level, Jimmy, have you gone over the HUD to zip file with your preferred county?
No. Let's actually, can somebody open that within the Enclave?
I can.
Okay.
Let's just get. So actually, why don't I go through? Here, I can just start from the. Let's see. I have the Enclave up.
Yeah, we do that crosswalk in our template using your that table already. So I think the main question from users is like, they have these 12 variables you all selected. How should they appropriately use them in research? So we already did the county to zip crosswalk.
Okay.
And so some of them maybe would, how do they correlate with this health data? What's an appropriate way to use it versus what's an inappropriate way to use these variables? And we could pull up the list of the ones that you included if that's helpful.
Yeah, I think looking at the list, so what you'll definitely find is that if you try to use these as patient level variables, you're not necessarily going to get much out of them. So if you were to be, modeling COVID outcomes and you tried to include these, you probably wouldn't get much benefit because the level of granularity is at the county level. Now, one of the ways this can be appropriate, and for instance, I think the first use of these variables from this template is going to be in an upcoming paper on characterizing patients who have the long COVID diagnosis code. And so the way we've used it is actually in our patient population table to indicate kind of like the distribution like of our patients. Like, are they coming from areas like that are very well educated? So it's like it can be used as an indicator, like it can be used to describe your patient population. If you were to look at outcomes by zip or county, that could also be beneficial. So if you're trying to compare different locations, this is when it could be beneficial. You could use it in a patient level model, but the thing is you're just not going to get the level of gain you would get by doing it at a patient level. But it is something that can be used to kind of help show that all this data, like the patient population you have, is it all coming from areas where people tend to be very educated? Is it all coming from is all your data coming from areas where the percent of population, like a high percent of the population is living below poverty? So it can kind of give you a sense of more information on the demographics of your data. I think things like looking at the MDs. So the MDs one, so this is the MDs per 1,000 residents. That's something that you can use for as an indication of healthcare access. And so that could be beneficial in the sense of, you might want to say, do I have a distribution across these? Or you could also use this as part of your, potentially part of your selection criteria. If you want to look at counties that have poor healthcare access, a lot of people do research just looking at regions based on whether or not they have some of these issues. So it could also be incorporated into your inclusion criteria.
So we had a capstone team recently that used these for some of their modeling. They included some of these variables that the clinicians selected, and they were highly significant in predicting heart failure alongside the patient-specific facts.
Okay.
And yeah, they were, and they increased the accuracy of the model by adding them. So that was interesting. But a few of them, I think, that were not included in their model because they were less sure how to interpret them, were the percent walk and the percent public transit. Like you said.
So yeah.
Interpret.
So that's a great point. And so our rationale for selecting these, and I know Jimmy said that he showed like the overview of patient variables. We have our own way of classifying, like so these there should have been a column in there that has like transportation. And so part of the reason that we have those is like percent what those can be indicators usually for how the population's ability to kind of just get exercise in their work. The other reason why this is important in COVID is because, the more people using public transportation, these are things that impact a group's ability to shelter in place. And so that's why we have included these in the template. It doesn't mean that it's going to be beneficial for everybody's research, but it could be if it can be important for COVID just because of that issue with, do you live in an area where, a lot of people are just not able to shelter in place because so many people take public transportation, and therefore just the way COVID's going to travel through a community will be different.
Interesting. Thank you.
So
yeah, and I guess maybe one thing we can do to improve the template as well is actually provide like show the categories, like maybe have some description around these are resource deprivation, this is what the, these are resource deprivations, these are traveling behavior, and it's important because of COVID. Like maybe we can group these within the template to improve usability.
That would be great. Yeah, so I can put these back into Slack for you guys, and then you take a look at that grouping. That'd be very helpful.
I was gonna say that there's certain research questions which are at the individual level, and our research question was at a geographic, like county level. So we were trying to consider both the role of policy and these being like an environmental factor, like just where you live and the resources available to you can change how likely you are to be infected or not be able to shelter in place adequately. But for other research questions, particularly the ones that are interested at the patient level, so my take to that is that if you can get that from the patient and you have empirical information from them that they use the preferred mode of transportation or something is public transit, then that would be the best to kind of know that's what level of usage it is. But in lieu of that, then you can use some of these county level or geographic level information to impute for information you may not know about those patients. Like that would be it's imputation. That's my way of explaining. Like you take the larger population level of it and then you impute what's the likelihood that they are going to use those.
Could information like this be used to sort of, evaluate existing results along axes of social determinants of health? So if somebody's like, oh, I've discovered in my research that people who have these pre-existing conditions tend to go on to develop worse COVID severities, and then break them out into categories of, we looked across low access to healthcare, high access to healthcare. Do you think that's appropriate?
For some factors where you can change it and it's relatively inconsequential, or if any policies come into play and like say public transit, you no longer have to pay for public transit in an area, then I would say that that's a difference in choice and option, and that might be what was it before, how does it change the risk, and then did that get mediated by a policy action, right? And so is it different now during COVID world? But for some of those variables, like the level of poverty in the area that was there already before the pandemic had started, I'm not sure there's another good representative measure after the pandemic has started. So by and large, I would say like a lot of economies crashed or had like issues trying to maintain for the duration. So I'm not sure there's another way to represent what would be an after. These measures are all from like, before the pandemic. So we really just have a good picture of what was it like cross-sectionally at different times before the pandemic.
So Jimmy, can you remind me, what's the lag for the census? Like the 2019, that came out at the beginning of 2021, right?
Yeah, they're almost always a year behind, a year and a half behind. The way that the census.
So next year we can do the research that Sean's talking about before and after.
So, well, I mean, yes and no, because some of these data sets are not getting updated anymore. They're just legacy. So like BU ShareCare, they are actively trying to push out their data set as a sort of living data set. Theirs would be the newest in town, using the American Community Surveys 2019 version, I think, or 2018. But just think of like one factor has to happen first, and then the next things can happen. Census 2010. Every year after Census 2010, they have like a American Community Surveys imputed 1 year or 5 year estimate for what would it look like now. And that sort of moved up till 2020. And so the last one since 2010 was that 2019 projected data set. That's what's in American Community Surveys 2019. And then I think BU is thinking to update to that version. But for 2020, which was, I don't know how to explain it, but I would say that 2020 is a year where the data accuracy would be in question
Yeah.
because of a lot of people who died and their situations change. So, and it's the election year and there's a lot of other things about that. So yeah, but that would not change the American Community Surveys data set until 2 years later. So Census 2020, I think, was released earlier this year, like in January or something, but we have not ingested that into the Enclave.
Yeah, and so another kind of idea, I just wanted to say this before I forget, is that you know, if you're doing health disparities research, a lot of the health disparities research, it's very place-based. People get it from one center or another. And a lot of what people are starting to incorporate is maybe like the within health disparities, like within a hospital organization. So you can also think like, do you have, like when you compare patients within the same hospital, is it the same as when you're comparing them across? So you could even think about, and this is something we've been working on and we've started, but we haven't completed this research project, but actually looking at, if we're looking at, depending on where we draw the data from at these sites, are we always seeing a health disparity by either zip code or county level? You could consider like wanting to stratify your counties based on some of these variables in order to look more into where do you see some of the most extreme health disparities. So these could also be incorporated into those studies as well.
There, one of the data sets that was on that list is the Safe Graph neighborhood data set. And I think the intention of that data set was really to look at movement behavior, mobility, and that gets down to like a census block group neighborhood level. But I'm not really sure any data set or any research through the N3C would be willing to go down to that level. It's like at the boundaries of re-identification. But usually if you were going to use if you wanted to get as fine as possible to look at these factors of disparities, your local neighborhood versus the grander city that you live in, or the county that you're sitting in, how do you want to make those generalizations? Most of the time you'd want to get finer and finer. Yeah. But for what it's worth, these are data sets which are looking at imputation from the county level, right? And some of the data sets, Charisse, correct me if I'm wrong, some of them are actually zip code level. Like
yes, nothing in the template. So we did county just because there was some struggle with using. It used to be that if you imported these external data sets, you had to go through this weird kind of permission things in your work in the space. So we've removed some of that. I think moving forward, we're going to want to come back to what's in the template and see about adding some of these other variables. But we do have quite a bit of zip code level social determinants of health in the Enclave. They're just not yet in the template.
So yeah, some of them are actually zoomed up to aggregated up to county. Yeah.
So the template currently does county matching against county level data sources. And if we wanted to see how that looks, we could dig into the code to see how the crosswalk is done. But for the zip code level ones, that's incoming still.
Yeah, and we have and so that we just need to get together. We have a zip code level American Community Survey with the 2019 estimates, and I just had to relearn how to make. I'm really bad at making templates, and I had to have Andrew Gervin go again with me. So I'm hoping next week I can have, or no, actually, Sean, that was you. That was Sean who helped me with the templates this week. I met with both of you to help me with Enclave stuff, so I just got confused. But hopefully we can have that available shortly as well. So we are working to get more SDOH from the patient level to the community level and make it more widely available. It's just some things are still a work in progress.
Yeah, so as of now, we did in the fall get permission from the governance committee through working on this for all the class 4 social determinants of health data sets to be kind of automatically granted access for every project. And so this Boston Share Care one is an example of a class 4, and class 4 is basically like big aggregate data that's not at a patient level. So, thanks again for the SDOH team being part of that conversation. And it really helps, I think, a lot of groups use the public data sets in general, since so many of them are aggregate data, and then we don't have to go through this long process. But yeah, we're still kind of limited to the class 4 in terms of use in our templates, unless we're pulling directly out of the OMOP tables, which we can do in the future as well.
So I guess that zip code to county crosswalk was created for making some of those connections. The level 3 limited data set has at best zip code information, and sometimes it'll have county information. But for the most part, if any patients did have their zip code information in there, zip code and county are like trying to fit left and right hand over each other. They're just different types of polygonal structures, and they're configured differently. Sometimes they sit entirely within, sometimes they're at the boundaries. It gets, yeah, there's like there's that housing and urban development resource, which does generate a zip code to county crosswalk, but they really just make it like multiplicative. So if a zip code and county is just sitting on top of each other, and then on another one too, it doesn't help. So what I did was I generated that zip code to county 1-to-1 crosswalk, looking at if a zip code was at the boundaries of like 2 different counties, and most of its land area or the centroid of that zip code is actually sitting in a certain county, then we'll count it that way. And that's how it's like sort of like sliding the assignment. There may be some places, some populations where they're sitting in that same zip code, but on the other county. But this is a bit of like the error in noise, because we're going to take this general assignment that they're on the boundaries of that county, and we can count them in that way. But a caveat is that each time a census happens, these geographic boundaries get redrawn. So this is like a temporary fix until we actually start looking at the world using the Census 2020. But yeah, for now it's fine.
And in our template, we used your preferred county, the majority residents, right, mapping.
Okay.
So the zip code that had the most people in it in the county.
And another question is, do we want to have some standard language around describing the data source and the mapping for people when they want to submit papers? Anything? Is that something that we would need to do?
So I brought up the DUR that we originally wrote, and it had like the 2-3 sentences explaining the data set towards our DUR research question. So I was going to say, like, if anybody was interested in using those data sets from the knowledge store, if they needed like a 1, 2, 3 sentence simplification, they just reach out to us, and it's in our DUR.
But this particular data set was not in that DUR because it came later.
Yeah.
So this is the one. This is the language we have right now, Charisse, in our README for people to use.
Yeah, I'm just thinking. So I think. Yeah, and so we're just we just had a paper accepted in which we used that. I was just gonna say maybe I can grab the way and because we also had the citation we used, and then I think we even included like a caveat or something about let me Joanna, if you and I could maybe meet next week to hammer out the details of what we'd want to add, I think that would be beneficial. Maybe we can include more kind of helper explanation. And then you can put also like my email and Jimmy's email.
Okay.
Maybe in there too. So if people want to have more questions, they can just, that might even just, make things a lot easier.
That's great. Yeah, I like that this has sparked some thinking about really these end users, these Enclave users, and how it looks to them. So
Yeah, yeah.
one of the calls, we're kind of live thinking through this. But this is really valuable. Thanks.
This makes me think, I know that there's a working group sort of working on improving the knowledge store in various ways. And that's a good point. I think maybe it was Sharice that just mentioned it. Like if somebody uses something from the knowledge store that has a lot of logic involved in it, like it's a crosswalk table where you grab the centroid, and if the centroid's in the county and yada, 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 and then you want to use it in your research project, what do you put in your publication, right? Like there should be a methods
Yeah.
section that describes that logic, and they need to be able to grab it or understand it from the knowledge store object. And I don't really know a good answer to that. Like drop this in your method section blurb, or I've actually considered taking a knowledge object that I've presented and then sort of getting the code out, now that we can do that, pushing it up to GitHub and making a DOI out of it, and then putting, making, or maybe like an archive hub or something, so that people can actually just cite it. We did crosswalk according to DOI dot yada 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 yada, and researchers can then go and find it publicly on the web, just like any other citation.
So
I really feel like knowledge objects need to be citable, or at least we need to give people a way to describe the methods that are employed in them accurately.
Okay, so I have one question and one comment. So I think I'll start with the comment. The zip code to county one-to-one crosswalk. So that one actually was generated because it sort of hit critical mass and we needed an option for that. So I actually wrote that up, put it into a GitHub, and then shared that GitHub with Palantir so that they can ingest the CSV file output. So the code to generate that is also living in that GitHub. I have no intentions of like saying this is a perfect product. So that's why it's like, as soon as the next 2020 or like the next set of crosswalking needs occur, this is just the set of operations to like look at the geography and like making these assignments. But it's a bit ad hoc, and if you were going to use this, you would generally try to do this in like ArcGIS or something else. I did it in Python because I don't think you need to be that exhaustive. Okay, now the question is, I thought the knowledge objects actually are citable. So if it's the whole reasoning behind like, why are we templatizing all of our code whenever we have a research product and reaching a publication?
No, I think he means more like, how would you, like, if you're going to cite it, how are you going to describe it? How are you going to describe the steps? Right?
To like reviewers of a journal who don't have access to the Enclave.
Yeah, and they don't know how you might get reviewers who come back and say like, okay, well, how did you do the mapping? Because we know it's not one-to-one. So then making it easier for the user to just be able to go somewhere to find the description of the method, so that when you do cite it, you can answer those questions.
Yeah. Do we have a way to flag documentation that's actually the protocol? No?
I think these are open questions for there's like a knowledge store.
My sort of like gut response is like, that information on what are the step-by-steps would need to be in the method section of the publication, or the supplementary steps if it's like too exhaustive. But if this is actually something we want to refer to in the knowledge store, like living in the N3C Enclave, I don't know how that DOI process works. So, or how you would document that one DOI is the DOI for the protocol steps versus DOI of the data set.
Right.
Yeah.
Yeah.
Okay. Thanks, Joanna. Always a very, very, it always turns into a brainstorm and I love it.
As we always think of more. Thank you.
Any other questions or comments from others?
Looks like Manisha has a question.
Link an N3C to GitHub or site that has methodology for citation. I think that is possible, Nina. I mean, I think that now that we can export code, so we could take a template and we could export the code and put it on GitHub with documentation. People won't be able to run it outside of the Enclave because templates only run inside the Enclave, but they can review the logic and then any documentation that's associated with it. And that could be minted to a DOI.
You can correct me if I'm wrong, but I think for any knowledge object in the Enclave, which it's from an external source, so the code base or the data is from like a Census or something like that, there's a URL as part of the provenance for that knowledge object.
For external data sets, yeah, but for like derived templates and things.
Well, for
live in
well,
there.
I don't know. You wouldn't be able to generate a GitHub from within the N3C Enclave. So if that exists, then it came from outside.
Well, you can now. You can take a template in the Enclave and export all the code available with the template or whatever it is you produced your code workbook and get it as a Git repo. And then you can push it up to GitHub or do whatever you want with it.
Okay, so technically speaking, there would be a template equivalent in the N3C Enclave, and then there's potentially also a GitHub outside the Enclave.
Just for public review and citation, I guess.
Got
That's one idea. I don't know if that's the way that it should go.
I have much to follow up on. That would actually,
yeah, and
that
like
would
we
be
have
helpful
very
because-
complicated templates and people are using them, but I feel like they're not being as thorough in their methods descriptions as maybe they should be when they use these things. And so just in terms of scientific provenance, reviewers want to know exactly what went into the sausage making.
And it might be worthwhile for us to, in our larger SDOH group, in our domain team, like maybe get an update on some functionality or things around templating and different things in the Enclave. Because I think for a lot of us, especially those of us that got the early start, it's like, I feel like sometimes we're the least up to date on what's going on because we went through all the tutorials way back when. Yeah. And so we don't even know what's new. So Sean, if that would be something of interest to you, if you had, if we could get, if there are some things that are maybe like recent updates or something or is there like a presentation on that or something we could?
That sounds like that's a good idea. I could see a presentation or a training module or something that just sort of hits the high points on, reproducibility and publishing within the Enclave. Because there's like code repos where you can make your own Python libraries, and those are a little bit more exportable outside the Enclave because they're just regular Python libraries. Unless the Python code uses PySpark, in which case you have to assume that there's a Spark cluster that library can talk to. Or
yeah, because we haven't really worried about reproducibility outside of our own DUR, but I think it would be really beneficial for our domain team to be thinking more about how the work we're doing can be reproducible. So I think if we could get, and I find the Python repositories a little confusing, but I'm getting better. So I think if we had maybe like a presentation for our group so that everybody can kind of be up to speed, I think that would, and I think it would need to happen within our domain team just because that's where we already it's already the time we're all together. And so I think that could be, reproducibility initiative. Yes, that would be, I think it'd be really beneficial to also come to the domain teams to do those presentations. So yeah, we can set up one.
The SDOH domain team, or we can figure something out.
Okay.
You are very welcomed.
Yes. Come anytime.
Yeah, anytime.
Knowing that it's a hard problem. I mean, the Enclave is just so unique compared to, it's not like you're putting together a Jupyter notebook that you can publish somewhere or.
Yeah.
I mean, it is a hard problem. The system that we have is just not what most people have access to. And so reproducibility is just not easy.
I just want to throw in one comment about exporting a code workbook to a GitHub repo, which is certainly feasible using tools that Palantir has created for us. However, if your code workbook is a combination of several different languages, for example, Python and R or Python and SQL, the code of each transform will wind up in a file with other transforms of the same language. So if you have, 10, say you have 10 transforms in a code workbook and 5 of them are Python and 5 of them are SQL, the 5 Python transforms will get grouped together and the 5 SQL transforms will get grouped together, but they'll be in different files of the eventual repository that you wind up with on GitHub. So what I'm trying to say is all the code is there, but it becomes a little bit of an intellectual exercise to figure out what the exact order of execution would be. If you're trying to infer from the GitHub repo, what is the order of execution of this code workbook? That is, I would say, I've never done it myself. I've never actually attempted to do that, starting from the GitHub repo to recreate in my mind the code workbook, but it's a little bit challenging depending on the actual sequence of transforms and what language they were written in. So it's definitely a step toward reproducibility, but it ain't no magic solution.
That sounds like it actually is an incomplete representation of the pipeline. It's just bunching the code, packaging the code for export, but not the pipeline.
Yeah, I as I said, I have not looked at this problem in detail because I have yet to export a code workbook to a GitHub repo, so I haven't actually tackled this problem. But it may be that by looking at the, my question is, how are the parameters specified for each function that corresponds to a transform? How are the inputs specified? It might be that with a little bit of work, you could recreate the sequence of execution by looking at the outputs of one transform and the inputs to the next transform. You could sort of reconstruct it. But I don't know how feasible that is. I haven't tried to do it. I agree with you. The representation of the code workbook is not really obvious from the repo you would get in GitHub, but at the very least, you get the code of each transform in your repo. So you could, conceivably go back and maybe reorganize it in a way that makes the actual logic of the code workbook easier to follow. I don't know. I haven't done it myself.
I've seen the others talking about you get a dump of the transforms from the code workbook, but it's not pretty and it's not well organized and woe be unto anyone who actually has to go in and try and tease it back out.
Yeah, that's what I was trying to say.
Yeah. All right, y'all.
Thank you.
Thank you all so much. Good discussion. Hopefully we get to talk more about the social determinants of variables and making use of them.
Yes, thank you.